Hi, my name is Kitty Lee Huang, and let's next move on to cardiovascular pathology, a very high-yield topic on the exam. We'll start with a discussion of some common congenital heart diseases that can affect newborns. When it comes to congenital heart disease, there are basically two important categories to keep in mind: early cyanotic lesions and cyanotic lesions. The first group is called early because babies born with these diseases will immediately show signs of cardiovascular distress, including cyanosis, after being born. We will talk about the first two of the 5 T's on this list, tetralogy of Fallot and transposition of the great vessels, in a few minutes. Right now, we'll focus on the other 3, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return, or TAPVR. Truncus arteriosus is where there is one vessel instead of the normally separate pulmonary trunk and aorta, which is a result of the failure of the truncus arteriosus to divide. Tricuspid atresia is an absence of the tricuspid valve, which is associated with hypoplastic RV and requires both an atrial septal defect and ventricular septal defect for viability. Total anomalous pulmonary venous return is where the pulmonary veins carry blood back into the right heart circulation instead of the left heart. Any of these 5 lesions, tetralogy of Fallot, transposition of the great vessels, tricuspid atresia, or TAPVR, will lead to cyanosis that is recognized at birth. On the other hand, the second group of congenital heart lesions is marked by late cyanosis, meaning that these patients don't develop signs of cardiovascular distress until later in life, often in childhood or adolescence, but sometimes even in adulthood. These include ventricular septal defects, or VSDs, as well as atrial septal defects, or ASDs, both of which are abnormal connections between the 2 heart chambers. What are the heart sounds associated with VSDs and ASDs? As you remember back to the heart sounds we covered in physiology, VSDs are holosystolic murmurs that accentuate when afterload is increased, such as with a hand grip exercise. ASDs, in contrast, cause a loud S1 and a wide, fixed, split S2, also known as a mid-systolic pulmonary ejection murmur. The final type is persistent ductus arteriosus, or PDA, where the fetal connection between the pulmonary trunk and the aorta remains open after birth. It's important to remember that PDAs can be easily closed with indomethacin because the prostaglandins are involved in keeping them open, and NSAIDs like indomethacin interfere with prostaglandins. VSD is the most common, followed by ASD, and then PDA. The reason that late cyanosis lesions actually end up causing cyanosis is something called Eisenmenger syndrome. What happens in this case is that there is a shunt somewhere in the heart that allows blood to flow from left to right, such as VSD, ASD, or PDA. Over time, this causes compensatory hypertrophy of the pulmonary vasculature, which in turn causes pulmonary hypertension and resultant right ventricular hypertrophy, which you can see here in the diagram. Eventually, due to the increased pulmonary resistance, the pressure in the right side of the heart becomes larger than the pressure in the left side, to the point where the blood flow through the shunt reverses, causing cardiovascular distress and cyanosis. Depending on when this reversal happens, the patient might present with frank cyanosis, when the skin turns blue, or subtler symptoms such as nail clubbing or polycythemia. Let's now go into more detail about the tetralogy of Fallot. Tetralogy of Fallot is one of the most common early cyanotic congenital heart lesions, and it's very high yield on your exam. As the name suggests, it consists of 4 important lesions and is caused by anterosuperior displacement of the infundibular septum. The most common area is pulmonary stenosis, and the degree of pulmonary stenosis actually drives the prognosis. The other 3 are right ventricular hypertrophy, overriding aorta, where the aorta receives blood from both ventricles, and a VSD. This can be remembered with the mnemonic PROVE. Early cyanosis is a result of the right to left shunt across the VSD, which is caused by the stenotic pulmonic valve. For the boards, a typical patient will present with cyanotic spells, and on X-ray a boot-shaped heart can be seen due to right ventricular hypertrophy. They will often squat to help alleviate their symptoms. This helps since the squatting increases the total peripheral resistance by compression of the femoral arteries. This then decreases the right to left shunt and more blood moves from the right ventricle to the lungs. The other important early cyanotic congenital heart lesion is transposition of the great vessels. As the name implies, this happens when the aorta and the pulmonary artery are transposed, meaning that the aorta comes off of the right ventricle and the pulmonary artery comes off of the left ventricle. What is the embryological failure that occurs to cause this? Well, this occurs when there's a failure of the aorticopulmonary septum to spiral. This basically creates two separate circulations, one for pulmonary blood and one for systemic blood. As you might imagine, this lesion is fatal unless there is some shunt, such as a VSD, PDA, or a patent foramen ovale that allows for sufficient mixing of these two circulations. As with tetralogy of Fallot, transposition of the great vessels must be corrected surgically in order for the patient to survive. Moving past the cyanotic lesions, we now come to coarctation of the aorta, where the aorta is narrowed. Something causes the aorta to narrow, and everything distal to that point of narrowing receives poor blood supply that leads to symptoms. For example, in the infantile type, the stenosis is proximal to where the ductus arteriosus inserts. This is commonly associated with Turner syndrome. In the adult type, the stenosis is distal to the ligamentum anteriosum. Collateral circulation can cause notching of the ribs and hypertension in the upper extremities. In both infantile and adult cases, blood flow to the lower extremities is reduced. Thus, both types lead to weakened lower extremity pulses. All infants should be checked for pulses in upper and lower extremities to ensure that coarctation is not an issue. Another commonly tested cardiac lesion that we've already mentioned is a patent ductus arteriosus. As we discussed in embryology, the ductus arteriosus is an arterial shunt that functions in utero to allow blood flow from the right side of the heart, i.e. the pulmonary artery, to the left side of the heart, i.e. the aorta. Normally, at birth, the sudden expansion of the lungs causes the pressure gradient to reverse, and this very quickly leads to closure of the ductus arteriosus and eventual conversion into the ligamentum arteriosum. However, if the ductus remains open, blood flows continuously from the aorta into the pulmonary trunk, leading to the machine-like murmur often heard. As we mentioned before, indomethacin is useful in closing PDAs, and on the flip side, prostaglandins like PGE are useful in keeping them open when they are needed, for example, in the case of transposition of the great vessels. Finally, we'll end our discussion of congenital cardiac defects with a brief mention of these important associations. You should take the time to memorize these on your own, because they tend to be very high-yield associations. In particular, Down syndrome and congenital rubella are associated with a wide variety of heart defects, whereas Turner syndrome and Marfan syndrome are primarily associated with one lesion each. Mark this fact as something to come back to and memorize. Okay, now let's move on to some much more common cardiovascular pathology. When it comes to the United States, heart disease is the #1 killer, so when it comes to your exam, all of this information is going to be quite high yield. Let's get started with hypertension, or high blood pressure. Formally, this is defined as a blood pressure of greater than 140/90. There are many risk factors for hypertension, important ones being increased age, obesity, diabetes, and smoking, as well as different races having a different propensity for hypertension. 90% of hypertension is essential, meaning we don't know what caused it, and it is related to increased cardiac output and total peripheral resistance. The other 10% is basically a result of kidney disease. Once a patient develops hypertension, it carries with it increased risk for a number of cardiovascular and other diseases, such as atherosclerosis, left ventricular hypertrophy, stroke, congestive heart failure, renal failure, retinopathy, and aortic dissection. Although hypertension itself is rarely deadly, except in the case of malignant hypertension, which is severe, This is a common condition that can elevate a person's risk for serious complications. Next, let's move on to hyperlipidemia, and specifically the clinical signs that may arise from it. In reality, nowadays most patients are screened with a serum lipid panel, and their hyperlipidemia is picked up long before any of these symptoms develop. However, they are important to know on your exam. Atheromas are plaques that develop inside blood vessels. Xanthomas are lipid-based plaques that develop in the skin. They appear as yellowish raised plaques. In this case, you can see one here on the eyelid, and they are called xanthelasmas. And in the case of lipid deposit in the tendon, it is called a tendinous xanthoma. Finally, if lipids are deposited in the cornea, they can make an arc shape around the cornea known as corneal arcus. Corneal arcus can be seen here in the picture with the light blue ring. Next, let's move on to discuss two important topics: arteriosclerosis and atherosclerosis. In general, sclerosis refers to hardening and scarring. So, arteriosclerosis refers to hardening of the arteries. There are three main types that you'll hear about. The first is uncommon, but you might hear about it on your exam. This first uncommon type is called Mockenberg's arteriosclerosis, and it's when the media of the arteries calcify without obstructing flow or involving the intima. This is usually benign and is typically found in the radial and ulnar arteries. The second type is known as arteriosclerosis, and this is the microscopic finding of hyaline thickening in small arteries. This is a pathognomonic finding of small vessel diseases such as hypertension and diabetes. The final type, and probably the most important, is atherosclerosis, which we'll talk about on the next slide. Atherosclerosis occurs when atheromas or fibrous plaques form within the intima of blood vessels. This triggers a pathway and eventually leads to the development of calcified plaques that obstruct blood flow. This typically happens in arteries that are large and elastic, such as the abdominal aorta, as well as arteries that are medium-sized and muscular, such as the coronary arteries, although some locations are more common than others. You might notice that the risk factors here include hypertension and hyperlipidemia, which we talked about before, and other risk factors we've seen before, such as smoking and diabetes. All of these conditions and risk factors are interrelated and modifiable. Non-modifiable risk factors are increased age, low estrogen states, and a positive family history. The full progression of atherosclerosis is quite complex, but you should know that it involves a number of key steps. First, what cells are involved? The cells that are involved are endothelial cells, macrophages, and smooth muscle cells. First, there's endothelial cell dysfunction, caused by defective nitric oxide production. This then leads to macrophage involvement and LDL accumulation. Foam cells are formed, and there's a development of fatty streaks, which leads to smooth muscle cell migration and proliferation, involving PDGF and FGF, and deposition of extracellular matrix. This then forms a fibrous plaque that eventually can become a complex atheroma. Atherosclerosis can have many complications, and they can manifest in several ways depending on which arteries are involved. But generally, you should think of ischemia and infarction due to decreased blood flow, as well as aneurysms, thrombosis, and embolization. Symptoms are related to these complications, such as angina and claudication, but they can be asymptomatic. Let's next talk about aortic aneurysms. One particular place where aneurysms manifest is in the aorta. These are dilations of blood vessels that are marked by weakening of the vessel walls. In the aorta, they are typically found in the abdominal aorta as a result of atherosclerosis. It is more common in hypertensive older male smokers. Aortic aneurysms can also be found in the thoracic aorta in hypertensive patients or those with cystic medial necrosis, such as in Marfan syndrome, or tertiary syphilis. Note that aneurysms are also commonly found in the brain, and that is discussed in the neurology chapter. Here you can see pictures of an abdominal aortic aneurysm on the left and a thoracic aortic aneurysm on the right. Aortic dissections are also commonly tested and high yield. This occurs when there is a tear within the intima of the aorta, producing a false lumen which blood can enter, which you can see in this image. This is associated with hypertension, Ehlers-Danlos syndrome, and cystic medial necrosis, and this is a life-threatening emergency. Patients will classically complain of severe tearing chest pain that radiates to the back. It carries high risk of mortality, either due to aortic rupture, which is rapidly fatal, or due to other causes, such as hemopericardium, leading to tamponade, or even occlusion of the carotid vessels. Now, let's move on to discuss ischemic heart disease, which is arguably the highest yield cardiac pathology that you'll need to know. In general, this is heart disease that results from cardiac ischemia, usually due to poor blood flow with atherosclerosis. There are many different manifestations of ischemic heart disease, and part of the danger is that one can change into the other without any warning. First is angina, technically known as angina pectoris. This is chest pain due to poor blood flow as a result of narrowing of the coronary vessels. However, there is no myocyte death as in myocardial infarction. In the stable state, there is retrosternal chest pain with exertion and is mainly due to atherosclerosis narrowing of the coronary vessels. On EKG, there is ST depression. Rest or nitroglycerin relieves symptoms. Prinzmetal's angina occurs due to coronary artery vasospasm, often in the setting of cocaine use. On EKG, there is ST elevation. In the unstable state, chest pain persists despite rest, and nitroglycerin tends not to help. These two types of angina can also be noted by ST depressions on EKG. Another important concept is coronary steal syndrome. This occurs when a vasodilator, such as nitroglycerin, actually worsens chest pain, and it happens because natural collateral blood vessels that have formed to perfuse the heart are suddenly deprived of their blood flow as it flows to other areas. The most dreaded of the ischemic heart diseases is myocardial infarction, commonly known as heart attack, which occurs usually due to acute thrombosis of a coronary artery with complete occlusion, and this leads to myocardial cell death. Within 1 hour, this can lead to sudden cardiac death, typically by means of a lethal cardiac arrhythmia, such as VFib. Finally, ischemic heart disease can be more chronic, resulting in a slow decline in heart function over time and eventual heart failure. Chronic ischemic heart disease results from progressive onset of congestive heart failure over many years due to chronic ischemic myocardial damage.